Good morning and welcome to the Methodist DeBakey Heart and Vascular Center Grand Rounds. Before introducing the speaker, there are some housekeeping items that we need to tell you. There are surveys. Please complete these so we can maintain our CME accreditation and continue to deliver the appropriate content for you. We are videotaping and live streaming. Please use the microphones to ask questions. A video of this conference will be available at the YouTube channel for the DeBakey Education YouTube channel next week. It is my privilege to introduce this morning Dr. Geoff Rose. Dr. Geoff Rose is the Chief of Cardiology at the Sanger Heart and Vascular Institute. I've known Dr. Rose for many years, back to 2004. Geoff had his training at the University of Philadelphia. He did his residency in internal medicine there, and he did his cardiology training and training in echocardiography at Mass General Hospital. He then moved in '96 to the Sanger Heart and Vascular Institute, and now he is their chief. Geoff holds the title of Clinical Professor of Medicine at the University of North Carolina, Chapel Hill, and also Professor of Medicine at the Carolinas Healthcare System. He has a lot of interests and has shared a lot of positions with several organizations. Geoff worked at the Intersocietal Accreditation Commission for Echocardiography. He served among the Board of Directors, Treasurer, and President. He was also on the Board of Directors and served as the Chair of that Board of Directors of the Intersocietal Accreditation Commission. Geoff has an active role with the American Society of Echocardiography. He has served on several of its committees, including the Finance, Guidelines, and currently the Advocacy Committee. He is the ASE representative to the RUC Committee. Geoff is currently the program chair for the scientific sessions of the American Society of Echocardiography that will be held this year in Maryland in the next few weeks. He has a lot of interests and most recently has looked into the changes in the healthcare system and healthcare delivery. He has lectured extensively on this topic, and today he will present to us on healthcare reform and the cardiovascular service line.
Well, good morning. Sherif, thank you so much for that kind introduction. And, you know, before I begin, let me just say what an absolute privilege it is to come here and speak with you all today. The caliber of the work that goes on here is nationally recognized, and you should know that. And just to have the opportunity to be here and visit with you is a real privilege. I have no relevant disclosures for this talk. What I'd like to do is a primer, if you will, on healthcare reform and try to make some sense of what's going on. The talk is really organized into three different sections. Why is it different this time? We've been talking about this for 20 years. Why is it different now? Some essential elements, some talking points that I think every provider really needs to know about MACRA legislation, why it's important, and so forth. And then last, I'm going to leave you with some specific things to be thinking about as a service line about how we're going to cope with the new payment landscape ahead. So those are really the three objectives. So as we move into it, why is it different this time? You know, I finished fellowship in the late 90s, and ever since coming out, every year doom and gloom, payment cuts, this, that, and the other, and we survived every year. Something, you know, we just managed to get along. Why is the tone and tenor different now? And let me take you through some of the elements that I think we all need to be fairly well grounded in. First, I think we need to recognize and really appreciate the fiscal challenges that are really driving policy. So if we think back to last summer, elections, et cetera, here's the biggest non-event of last summer. Last summer was the 50th anniversary of Medicare, okay? Groundbreaking program. This is a picture that was given to me by our colleague Mike Main at Mid-America Heart. This is President Johnson giving the first two Medicare cards to former President Truman and his wife, July 1st, 1966. Okay. We now have close to 58 million recipients of Medicare. And before we get too deeply into it, just to level set for a moment, I want everybody to understand the Medicare program, just sort of the basic elements. There's Medicare Part A, which covers reimbursement for all the work that we do inside the hospitals, the inpatient work. There's Part B, which is for how we are reimbursed for the physician services for the things we do, plus outpatient work that we do. The program was expanded in the early 70s to include dialysis and Social Security and so forth. Medicaid is a totally different program. Many people aren't aware of that. Part C emerged in the late 90s in the HMO era as a way to look at bundled care and basically per member per month payments. And then Part D, I think we're all familiar with recently with the prescription drug coverage. When we talk about Medicare, just as a general term, we're really talking about the collective elements of Part A, inpatient, Part B, outpatient, and prescription drugs. That's what we're talking about. And specifically, when we talk about MACRA and a lot of the changes that are coming, we're talking about that aspect of Medicare that affects the physician services component of outpatient care, of the Part B. Okay, so it's fundamental to our understanding about what we're talking about and not talking about when we talk about these legislative changes. So here's the problem. This is a graphic from the Wall Street Journal from 2 years ago. I've updated it a little bit to make it relevant for 2017. If you just spend a moment and absorb what's on this page, if you look at the left-hand side, this is a population curve from 1970. I put a circle around the tip of the spear. That's the population that at that time was 65 and older, okay? The ones who consume the healthcare resources, the ones for whom Medicare was designed, et cetera, okay? You'll notice at the bottom of that graphic, the wave, that's the baby boomers, okay? In 1970, they ranged from ages 6 to 24. Fast forward, okay? 50 plus years later, now look at the graphic, okay? What was a rounding error of patients over 85 in 1970 is now a significant population. The base of the triangle, if you will, above 65 has grown. You can see that the waves hit the shore in 2013 of the baby boomers turning 65, and it is not going to stop. Look at what's coming. This is, people call this the Great Tsunami. This is why, okay? You can see what's going to happen year after year after year. So if we already think that the Medicare system is taxed from a variety of perspectives, service, access, et cetera, we have some problems coming. If we look at just, expenses and so forth, we spend about $560 billion on this. We will continue to spend more. How fast GDP grows will determine what percentage of GDP we are spending on this, but we know it's just a math problem. We know we are going to be spending more money here because we're going to have more enrollees. So every year, MedPAC and the trustees who run Medicare have to deliver reports to Congress. And these are fairly comprehensive and long documents and so forth. But a couple of things are worth pointing out. If you take a look at this figure here, if you look on the left side and you just look at Medicare enrollment over time, what you're seeing is it's going to expand, what I just showed you, just math, right? The population is growing, we're going to have more and more enrollees. But look on the right side. Back in 1970, we had 4.8 workers per every Medicare beneficiary, okay? That number is dropping, and in 2030, the math is we will have 2.3 workers for every beneficiary. So we have a population that's expanding, we have a tax base that's supporting the payment that is shrinking. This is not a good situation, okay? And this is what's driving policy. If we take a look at this curve, in your paycheck every week, every month, there's that little Medicare piece that comes out, okay? That is to fund Part A, the inpatient trust fund. So we talked about Part B and Part D, but Part A, there's a trust fund, and that's what comes out of your paycheck, a certain amount every month. So there's a certain amount that's in reserve from the trustees of Medicare. This is the fate of that trust fund over the course of the next decade. it goes bankrupt in 2030. Now, you can say, well, okay, we'll just tax, we'll just write a check, right? We'll just tax more. But you know what the political climate is, et cetera, et cetera. So the money that's coming out right now is, the burn rate is faster than what's going in. Okay, so these are just the macroeconomic problems that are facing the funding for 55 million people. If we just take a look again at some of the projections, the economists say that the GDP will grow 4.4% per year. Who knows whether that will happen, but what will happen is Medicare enrollment will increase by 2.6% because we know what population, it's actuarial science. We know that that is going to happen. At present, the rate of growth of spending per beneficiary is increasing by 3.2%. So if you put that together, we're going to spend more than we're going to grow. So we would have to cut spending by about 1.6%. So there has to be some new way of thinking about this. Otherwise, we're just going backwards. So if I take a look here, just to frame this a little bit more, Medicare 101. So we spend about $560 billion. Just to put that in perspective, when a program saves $100 million, sounds like a big number, that's less than 0.02%. You get out your calculators. I mean, that's just mind-boggling what kind of numbers we're talking about. Right now, Medicare is about 14% of federal outlays. Untouched, it goes up to 27%. And as I mentioned, over 50 million beneficiaries that go up to about 82 million in 2030. That's what's coming. So, how do we connect the dots? I want to take you through just a couple of key pieces of legislation that you just need to have heard of as we sort of construct the narrative about how we try to find a path out of the woods here with respect to things. So the first thing I want to talk about is something called the sustainable growth rate. And for those of you newer to medicine who haven't heard about it, you're fortunate. For those of us who've been doing this for the last 15 or 20 years, this was the bane of our existence for a long period of time. What had happened when Medicare started out, there were never really any controls on how Medicare should pay physicians for what physicians do and other providers. It was usual and customary rates, which was, as you would expect, pretty inflationary. People just charge more and charge more and charge more. And there were a variety of efforts to try to rein this in, ultimately culminating in 1997 with the sustainable growth rate, which basically said if the economy grows, physicians and other providers will get paid more. If the economy contracts, they will get paid less. Everybody said this is a great idea. Late 90s, economy's hot, everybody's making, doing well, payments increased, and then all of a sudden the bubble hits, okay? Physician payment gets cut by 5%, everybody's screaming, okay? And thereafter, every year, actually 17 times, there were face-offs with Congress, AMA, physicians organizations, and so forth. You can't cut, reimbursement, we'll drop out of Medicare, et cetera, et cetera. And every year there was this sort of standoff, and then Congress would relent, only to say, that's fine, we're not, repealing the cuts, we're just going to put them in abeyance till next year. So by the time we got to MACRA, which I'll get to in just a moment, we were facing about a 20% cut in all physician reimbursement, just based upon the existing legislation. So this was a real problem in terms of how Medicare access, physicians saying, well, we're just not going to take care of Medicare patients and so forth. So a real national issue. The Affordable Care Act, where does this fit into this narrative? And I'm not going to talk about repeal, replace, and those types of things, as important as they are. Who knows where that is going? But here's something about the Affordable Care Act that I think we all should recognize in terms of what it put on the books, in terms of the things that we're doing every day and what our administrative teams are dealing with. So aside from access and how we're going to deal with Medicaid and so forth, one of the important and fundamental elements of the Affordable Care Act was to create payment that was linked less to volume and more to value, more towards quality. And, to illustrate that, this is just a graphic of a variety of programs that you may not be aware of that exist behind the scenes that influence payment back to our institutions when we deliver care. Most of these began or have their DNA in the Affordable Care Act. So we talk about things like accountable care organizations. Everybody's heard of that, may not know all the details of what exactly they are, but kind of understand that concept. All born out of the Affordable Care Act. When we look at things like hospital readmission penalties, when we look at what we call the physician value-based modifier, which is a quality modifier imposed on physician payments, all arising out of the Affordable Care Act, all ways to basically say, aside from the volume of the things that we're all doing, we have to come up with a way to somehow measure quality in some way. So if we take what exists that has arisen from the Affordable Care Act, this is just a snapshot that many, when I talk about this, aren't actually aware of in terms of what's going on behind the scenes. So today, when you see a patient and a bill is dropped behind the scenes and Medicare will reimburse you, the rate at which you're reimbursed is influenced by the performance of your organization in a variety of domains. So did you report out on certain quality measures, and how did you do? Do you use the electronic medical record, and have you met the requirements? Yes or no, that's the meaningful use phase. And then there's something called the physician value-based modifier, which is a very complex way of looking at episodes of care. All this is happening behind the scenes that most of us don't know because we're just taking care of patients. But when we take a step back, and as Sherif was mentioning, you know, as we sit in our professional societies advocating for resources to take care of patients, the RVU value for, you know, TAVR should be X, or reading an echo should be Y, or whatnot, you know, it turns out, I mean, metaphorically, we're fighting over nickels on that front, where on the back end, everything you're doing can be cut this year by 9%. Okay? So all of these programs exist out there. Your administrative teams are very aware of this, even if we're insulated from this on the front line, but it influences the revenue that's coming back, which ultimately influences the resources your organization has, you know, to sustain its mission. So where do we go with this? Enter MACRA. So people call MACRA the SGR Repeal Act. It's the Medicare Access and Chip Reauthorization Act of 2015. This was the pivotal piece of legislation that took away this sustainable growth rate issue. This took us away from having the annual fight with Congress about how much providers are going to get paid for the services that they perform. What it did was it put in a fixed increase in the payment for a couple of years, put a freeze in place, and then put in some other payment modules, which I'll go through in just a moment. But of the four things I'd like you to remember today, this is the first one, okay? MACRA is not going away. Independent of what happens to the Affordable Care Act or the next phase or what have you, this will not go away. And why is that? This bill was passed in a Republican House, 392 to 37, in a Republican Senate, 92 to 8, and signed by a Democratic president. This is not going away. There is bipartisan agreement that this fundamentally is how physicians are going to need to be paid into the next decade. So short of some other landmine that comes along, this piece is in the done column from Congress's perspective. So it's important that we have an understanding of what this all means and what we're going to do with it. Why? Well, there's belief on both sides of the aisle in this graph. And if you look at the dotted line and you look at what the trajectory of spending was going to be, it asymptotes out to infinity at some point. The inflection curve here, by all of the elements baked in together in the Affordable Care Act, bend the curve at 2030. Now, how much of this is related to physician payment and how much of this is related to other elements of the Affordable Care Act is a political debate. But the physician payment piece is in the done column, as I mentioned. So what's coming? So I mentioned all of these complex programs that are happening today behind the scenes that you may not be aware of, meaningful use and physician value modifiers and all these types of things. These go away in 2018. In 2019, they're replaced by something called the Quality Payment Program. This is the chassis, if you will, of MACRA as we move forward. So you're a provider, okay? you will fall down into one of two tracks. If you're part of an accountable care organization, if you provide organized care and an ACO and so forth, and a variety of complex requirements, which I won't go into in this talk, you will be in the APM track. And I'll talk about the financial ramifications of that. 90% of providers will be in what is called the MIPS, the Merit-Based Incentive Payment System. So we'll talk about what MIPS is. But these will be the programs that go into place that will influence and directly influence your payments moving forward from 2019 onward. So what does this all mean? So based upon Medicare billings, you're going to get put into one track or the other. The alternative payment models, as I mentioned, are things like next generation ACOs. There are Medicare shared savings programs. There's a variety of programs there, and if you meet certain revenue triggers for your organization, you move into an APM track. And I'll talk about the advantages of that in just a moment. If not, you wind up in the MIPS track. Why is that important? Here's how payment will work starting in 2019. So if you're in an APM track, everything you do, every bill you drop as a provider, you'll get a 5% bonus off the top, okay, for 2019 to 2024. No muss, no fuss, everything you do, 5%, okay? If you're in the 90% who are not in an alternative payment model, you will be subjected, is probably the right word, to scrutiny in terms of your performance on a variety of domains, from quality to care initiatives to so forth, which I'll walk through in a moment, which will influence how much your payment comes back from Medicare. It will begin at you can lose 4% of everything you do to, in 2025, 9%. Okay? Flip side is you can gain 9% if you're an exceptionally high performer. This is a zero-sum game. People are going to lose, people are going to win. The people who do better are going to take from the people who are doing worse. That is how it's funded. There's some extra dollars that are coming into the program for exceptionally high performers, but this is basically providers against providers on a national level. That is what is happening out of this plan. In the meantime, in terms of the payments that we get for the procedures that we do, everything is frozen. Okay? 2026, there will be an increase on an annual basis of 0.25% if you're in the MIPS program. If you're in an APM, like an ACO, as I mentioned, it'll be a 0.75. The clear reading of this legislation among those in the healthcare circles is this is a push to get everybody into some type of alternative payment model, some type of ACO plan, some type of bundled plan, something along here to improve care integration and so forth. Otherwise, you're kind of in the Wild West of what this MIPS program is going to be. Here's what's interesting. This starts in 2019. Everything you do in Medicare, it's like Starlight. You see it 2 years after it actually happened, right? This, we're in the performance period right now. How you are taking care of, how we are taking care of patients today in terms of quality metrics, cost, and so forth, is being accounted for, will be reported in 2018, and will determine our 2019 payment. That's just how Medicare works. It's always 2 or 3 years backwards that's applying. So by the time you realize it, the problem's already 3 years old. And in order to fix it, it takes you another couple of years. So it's one of these things as organizations we just need to be aware of in terms of how it works. I'm not going to spend a tremendous amount of time on the dynamics of this. This is really just so you've heard it, you've seen it. When you hear about committees in your organization that are working on it, you'll have a connection point to what this is. But within MIPS, for the first year, the way that we are all going to be evaluated is going to be based upon 60% upon the quality that we provide. I'll talk about how that is assessed. Another percentage, 25%, on what was called meaningful use, but basically how care information is shared. And then a new category about care integration, which is called clinical practice improvement activities, which I'll speak to in a moment. Cost is not going to be a factor in the first year, but moving forward, the cost of care is going to be one of the key determinants of this. If it costs us more to provide care, our scores will go down, the reimbursement goes down. It's basically how it works. It's the government. It's complex. There's a lot of moving parts here. There's different domains, as I mentioned, with quality, clinical practice improvement, advancing care information. But just to walk through this for a moment, cardiovascular organization, what would be the quality metrics that people would want to know? Here's some examples, and I've got some references at the end of the talk, which I'll leave behind, about where the quality metrics can be viewed. But you can report on the number of stress imaging cases you do that did not meet appropriate use, okay? And it's not only reporting, but how do you stack up against your peers nationally with respect to that metric? You can look at your Medicare population and how well is their hypertension controlled, and there's parameters on how that is reported electronically and so forth. Again, it's one thing to report, it's another thing to actually perform relative on that metric to your peers across the country. How you do on all of these, it's one thing, as I mentioned, to report, it's another thing to perform, and how you perform will then ultimately determine on an individual provider basis what your score is. Okay? And that just takes care of the particular quality domain. The same thing, and I'm not going to spend time on this because I just want to give some sense of just how complex it is behind the scenes where all this is being calculated. So we take care of patients the way we take care of patients. The data go out, they're analyzed, they will come back to us. Let me just talk about clinical practice improvement activities. This is a new category. So does your organization have same-day appointments for urgent needs, yes or no? Okay, if you do, you report out on that, and that gives you points around coordinating care and so forth. Do you use telehealth or group visits? That's another parameter. So for each of these metrics, there's a whole variety of choices that organizations can use to pull together to give a reflection of the care that is provided. But these are proxies for performance, but it's what's out there. But the message that I'm trying to convey is how you do as an organization, or how my organization does at some level. There's a competition that will be going on nationally because there will be a score, there will be a number, and those who are above a certain cut line will get bonuses, and those who are below a certain cut line will have reductions in terms of their payment. So 2017, as I mentioned, we're in the performance period now. We'll get updates in July to our organizations about where we stand. You can actually go to Medicare's website today and type in your national provider number, and it will tell you where you stand in terms of this program. In July of next year, we'll get feedback, and we'll learn whether or not we're getting cuts or we're getting bonuses to our organizations on this, and then those go into play in 2019. And then the same thing happens in 2020 and 2021 and 2022. So again, most of us in our organizations have various compensation contracts and so forth that are independent of all of this, but the resources that are coming back to our institutions to support the work that we do are directly tied into this. So to think that this isn't going to be important at some level, would really be incomplete. So it's important that we have an awareness of this. Graphically, just as I mentioned, this is the sort of winner-loser capability here that happens out of the MIPS program. And this is why most in circles feel that moving to some type of alternative payment model is the safe harbor, because this is kind of the jungle. This is, performance that's hard to measure. What's the relevance of the metrics that are being measured? Are they accurate, et cetera, et cetera? But at the end of the day, losing 9% of revenue on the work that you do is a pretty hard pill to swallow. And then graphically, this is just what it looks like over time, just in terms of which side of the 0 point you're on in terms of organizational performance. As an organization, as I mentioned, in this quality program, those in your organization who are in charge of doing these types of things, reporting out your quality metrics and so forth, have a variety of reporting options, and then obviously the easy button down here is in the alternative payment models and so forth. So with that complex backdrop in terms of how payment is happening, the fact that it's not going to change, About the only thing that's seeming to happen is delaying implementation and some of the trigger points in terms of the percentages, but the fundamental, as I mentioned, chassis is not going to change. What do we do? You know, how do we deal with an environment where we're going to see diminished payments that are coming in, increasing need because the population is expanding? How do we begin to cope with all of this? So let me just walk through some thoughts in terms of how one might approach this. First of all, how does Medicare even know who you are? Basic question. Okay. So if you're a provider and you bill for services, you have a national provider number, NPI number. Okay. Second level, most organizations, and I'm sure this is the case here, organize their providers into something called TINs, tax ID numbers. So, for example, in my organization, we have 2,700 physicians. We're organized into 50 different TINs. They don't look at my particular performance. They look at how my TIN does. And how my TIN did is how I did. So it all becomes how your group does. So the tax ID number structure becomes fundamentally important. Why that becomes important is because when these tax ID number things were created, they weren't created as performance vehicles. They weren't created to measure how well you take care of hypertension or how well you take care of heart disease. They were solely vehicles so that your organization could get paid. If you're going into a private practice, someday it's how, you know, Medicare pays the practice. But they now have been co-opted to become performance vehicles and providing the only window on how you or I perform in terms of the care we deliver. So we need to know a little bit more about that. We need to know a little bit more about that at an organizational level. And then for the administrative folks in the room, this is a really important point. The fact that a cardiologist is an electrophysiologist means a great deal in the eyes of Medicare. Not that they're an internist, not that they're a cardiologist, but that they're an electrophysiologist. And why is that important? Electrophysiologists spend a lot of money. They put in devices in Medicare patients. That's what they do. They're supposed to do that. If you have an electrophysiologist who was classified as a cardiologist, not an electrophysiologist, it looks like that cardiologist is spending an awful lot of money, okay? Because the patient is misclassified. And this system, this PICO system for the administrative folks, this is how Medicare knows that Dr. X is an electrophysiologist and Dr. Y is an internist and Dr. Z is cardiologist. So this becomes fundamentally important because this influences the calculus of what's going on behind the scenes. The second thing I want you to remember from this talk today, QRUR, okay? The QRUR is what's called the Quality and Resource Use Report. This is Medicare's report back to your tax ID number every year of how everybody in your tax ID number performed, okay? So again, as an individual practitioner, you may not have had access to this. As an organization, people are looking at it. Again, for those of you in practice or going into practice, this is an important tool. This is basically Medicare's scorecard of your performance, okay? And I'll walk through some of the things that, you know, that we can learn from it. Everything that's in here is based upon claims data, billing data, okay? Things that are reported on the website. And from this, episodes of care can be constructed. There's risk adjustment and so forth. So the QRUR is really important. Third thing I want you to remember from the talk today, when we talk about cost, there are two ways to think about cost. The sort of common sense way is how much did I spend to take care of this patient? What resources did I use? Did I order 3 kgs every day? Did I do too many tests, et cetera, et cetera? That's really important in terms of care delivery, and you know, those in your service line are you know, care about that kind of stuff. But from a Medicare perspective, they don't care about that aspect. What they care about are the charges, right? And charges are based upon DRGs, right? So how much did you spend on Mrs. Smith for her care this year? How many times did you use a DRG because this patient was in the hospital, maybe didn't need to be in the hospital, but now was? That's a spend. Did that patient go to a nursing home after the hospitalization? That's a spend, et cetera, et cetera. So every conversation that we have in topics like this around cost all center on charges. I don't want to dismiss the fact that true costs are important because they influence the ability of your organization to deliver the care you want to do, right? We want to be efficient, we need to be effective, but they're two different, this is a bifurcating point that I think people need to understand. Let me just go quickly through what a QRUR report actually does. So this QRUR report for your organization, I'll assume everybody here is in the same tax ID number. What will happen is at the end of the year, they'll get a report. These things come out in September. So September 17, we'll learn how we did in 16. There will be an aggregate score. Your quality was X and your cost was Y. And you want to be up in sort of that northeast quadrant of low cost, high quality based upon benchmarks, because then that will drive reimbursement in terms of performance. Obviously, the southwest corner, if your high cost, low quality, is not the place where you want to be. And the QRUR report gives you this sort of global score in terms of how you're doing, but it also provides drill down data on how the score was calculated. So for example, do your hospitalists order more echoes or fewer echoes on heart failure patients than your cardiologists? Do you know? Okay. Well, you actually can find out in your QRUR report. Okay. How many echoes do you get for your post-MI patients over the course of the year? Okay. Do we know? It's in there because, and importantly, how sick are your patients relative to the patients who are taken care of across town or across the country? How do you know? Okay. Fourth thing, okay, coding. This is the bane of everybody's existence, but I have to mention it because this is going to become even more important as we go forward in the next decade, and we just need to kind of come to terms with that and begin to figure out workable solutions in terms of our daily work. But the only way an insurer knows how sick that patient is in front of you, that you're taking care of, and thus how much resources that patient is going to need, is based on billing data, claims data. That's the only insight. You can write the best note out there to your colleagues and everybody else, but the payer, whether it's Medicare or whether it's private insurance, only knows how sick that patient is solely by claims-based data. And that is a real gap in our operations back home and in many organizations because it hasn't really been something that we've had to think about. Those who have been in the value-based world and in Medicare programs and so forth have, learned this lesson a long time ago. I'll just kind of go quickly through this. So this is a case example. So you're seeing a patient in the office, has diabetes, chronic renal failure, and comes in for heart failure, relatively stable. They're going to see the nephrologist next week and so forth. Okay, standard visit, you took care of the patient got what they needed, they did well, and you billed at the end that this patient had heart failure and so forth. Yeah, you get paid, okay? But when somebody takes a step back and said, how sick are the patients that you're taking care of, the fact that you didn't put a claim in, you're not going to get paid any more that day because the patient had diabetes or the patient had heart failure. That's not the issue. The issue is really, how sick was this patient from a population standpoint? The only way that is known is if those diagnoses somehow are captured over the course of the year in the record of that patient. And this is a very, very big gap. And let me show you how this has cost us. Okay, this is coding, and this is back in my organization. So we're, 40 hospitals, big organization across North Carolina, South Carolina. The hospital where I practice is in the red, in the bottom, okay? This was how we did in taking care of patients with acute myocardial infarction, according to reported data to Medicare, what they abstracted. Our colleagues 90 miles up the road are in the green, okay? We were absolutely stunned when we got these data because we just had gotten our, Platinum Plus, award from the Action Registry on our performance, for AMI care and touting that in billboards and, and we get this back. So we go through the case level data and we find that of the 300 cases that made their way into the Medicare database to analyze us, we actually looked at the cases. A third of the cases were not things that you and I would call heart attacks. You know, strokes with troponin of 0.1 and, you know, sepsis and troponin of, you know, 0.6 and et cetera, et cetera. Medicare doesn't know. Medicare doesn't know the difference between that patient who we kind of think medically and, you know, demand ischemia or what have you, myocardial infarction, but this is the real implication. Now, the dollars associated with this are small, but this is very telling in a value-based world because this is the only insight that the payer community has into the performance of the work that we all do. So it's a sobering thought, but whether you're, you know, practicing here or in, you know, in an independent practice or moving to another organization at some point, there has to be an awareness of this because this fundamental element is not going to go away over the course of the next decade. So just, you know, in closing, because I want to leave some time for some questions, so just a couple of must, and, you know, and I'll certainly be happy to leave slides behind for anybody who is interested in this as a resource material. These QR/UR reports organizationally are really important. You can gain a lot of data about how Medicare is looking at the care you're providing. It's your scorecard. You should be aware of what's on it, how it got there, and basically use it to get into the case level detail to uncover variances within your organization. And offline I can give you examples of how we've used this. But ultimately it's going to need to lead to some type of ways to constrain variance in practice and become more standardized across the board. So I want to finish with something that's called bundled care. And this is a whole talk on its own, but just not to mention it I think would be a disservice. In addition to MACRA that we talked about how care is going to be assessed for everything that you do, we're also in an era where episodes of care are being bundled together. So the patient who comes in who needs a cabbage, well, we can think about all the resources that that patient is going to consume for the next 90 days and package that into a price. This is what it's going to cost. In fact, some leading organizations have already done that, know what their costs are, and have gone out to private insurers and said, we'll do your cabbages for a fixed price and so forth. Retrospectively, what Medicare is doing is saying, we're going to actually begin to take things that are predictable and begin to organize them. The variance in cost for cabbage and AMI care across the country is 50%, 50. What other business has a 50% variance in its core service? None. None. So this is what's driving this. In a bundled care arrangement, there's an episode of care. The sort of darker triangle is the event. If it's an elective procedure, the bundle may actually begin day -3 before the event. So cabbage, elective cabbage, it may be that it's a couple days before, and then everything that happens that is relevant to the cabbage is counted in the cost, as I mentioned, the charge data over the course of the next 30 days or 90 days, depending on the bundle. Things that have nothing to do with the care, the patient needed an appendectomy on day 72, that cost wouldn't be in there. But that's how these bundle type arrangements work. Now, do they work at all? There's actually some lessons here. This is from the orthopedic literature, and this is from the Banner Health System down here in Texas. When they looked at CJR, when they started in 2009, it cost them close to $27,000 to deliver care for hip and knee. By the time they got done, it was 21. So they were able to reduce their cost by 21%, while those not in a bundle, costs actually increased by 5% over time. They saw no drop in quality. They weren't cherry picking the good cases. There was no change in things. So just by organizing care and developing pathways and so forth, you can begin to constrain costs and be able to give a more standard product when we're also looking at it through the lens of cost and resource utilization, which is going to have to be a discipline that we become acquainted with. And, you know, as we're finishing up here, you can organize the same thing around bundles. This is just an example of our pathway that we have for ACS and a non-PCI center in our system. This is the pathway that people use. You can deviate from it, that is fine, but all things being equal, these are the things that we want you to do. This is all evidence-based. This is all, you know, done, you know, so it makes it, you know, fairly standard in terms of how we can approach things. What's the impact of that? If you take a look, and I was talking to some folks over dinner last night. We have 13 interventionalists in 3 sites. Our bivalirudin use at site 1 was 90%, and at site 3 was 10%. Bivalirudin's $900 and heparin's a nickel, I don't know, something like that, right? We began to share these data across our board, and you can see where we stand today, okay? That has saved $600,000. If your hospital's margin is 4%, okay, you need to do $15 million in revenue to come up with $600,000, or you can save $600,000, okay? Service lines are going to need to be thinking about this, and the changes that are happening in terms of legislation are forcing us that way. Some would argue that it's long overdue. It's not just, you know, enough to provide the great care that we do, but we have to think about how it's organized and how efficient it is. So as we close, just some things that we talked about, knowing the taxonomy for the administrative folks of all the people that are in your tax ID numbers is critically important. Knowing your scorecard with QRUR is critically important. Knowing that coding is really going to be important, and as you develop coding subcommittees, those of you who aren't on those committees, give them some sympathy because that's what they're trying to help the organization with, and let's try to figure out the right tools. Just a reference, you know, this is the Federal Register in terms of where all the resources lie for some of the things we talked about. But this is a profound quote, one of my favorite quotes. William Gibson is an author. He coined the term cyberspace, interestingly, fun fact. But the future is already here. It's just not evenly distributed. My market in the Southeast is just beginning to tap into the value world. We're still volume. That's just the local economics. I don't know why it is. But you go to Southern California, or you go to Wisconsin, or you go to Minnesota. I mean, this is already there. And it's coming. If it's not here yet, it will be. And it's just a question of how prepared we're going to be when it happens. So these are just some of the things that I'd like you to think about. And just in closing, we've got 321 million people in the United States. Fewer than 50% can actually afford the care that they get. By the time you add up Medicaid and CHIP, by the time you look at Medicare and you look at the uninsured population. So whether you believe in the Pangea of single payer or whatever the answer is, something is going to need to happen because just a fundamental business principle, if you're selling a product that everybody needs and only half the people can afford, you've got to really rethink your strategy. And if we don't rethink it from inside, it will come from outside. And I think those who've had the ability or the chance to be on, policy circles have already seen that, beginning to happen. So these are the things that we can't feel are put upon us. These are things we have to understand and then use our, our energy and our intellect to try to figure out ways to best take care of our patients. So I'm sorry that was a long whirlwind. I'll stop there and leave a little time for questions, but thank you very much for your attention. Appreciate it. Sir.
About 30 to 40% of traditional Medicare patients are enrolled in Medicare Advantage plans.
Yep.
So what you said apparently affects the Medicare traditional, but how does it affect the Medicare Advantage plans?
So simple answer is it doesn't. Okay. So Medicare Advantage plans are going to be dictated on per member per month types of arrangements. Okay. So Medicare will pay whoever's executing the plan, whether your organization is serving as an insurer or whether there's an insurance company that's selling that as a product, will, pay a certain per member per month payment. Then it is a negotiation between the providing organization and the insurer on what the rates are. Okay? So you're not billing the government, you're billing the insurer. Okay? But the funds are coming, and the advantage from a Medicare perspective is it's knowable, right? If you've got 10,000 people in an MA plan and you know what their cost is going to be per member per month, there's no variance. Here it is. So Medicare's writing a check, it's very predictable, whereas in traditional Medicare, it's open-ended, right? It's whatever that patient goes through is going to be charged along the way. So the per member per month is an advantage, if you will, for Medicare, and then this is where you get into the very detailed work at the insurance company level of figuring out how to administrate an MA plan. Most people feel that as we keep going forward and we can bundle care and make things more predictable and so forth, that ultimately it becomes a per member per month type of, fiscal arrangement with certain quality benchmarks in there. We were in the per member per month in the HMO days, but there were no quality metrics, and it was just basically less care. We're now in an era where we've got the capability to measure more things and, and put some quality safeguards in. But for the most part, all these things that we're talking about are really ways to constrain cost because of the macroeconomic issues that, I tried to lay out.
Jeff, fantastic. Great overview. I mean, in all the unlimited capacity of medicine, it's amazing that we just heard a whole bunch of new acronyms. It's really amazing. So question about how does the responsibility for quality get shifted between providers? Because we all have patients who, they have multiple providers, some long-term, some short-term, and they may come to see you on an outpatient basis for one specific thing, yet they've got these other problems. And maybe you see them for the aortic stenosis, but they've got hypertension and they've got whatever. How does it get partitioned in terms of the responsibility for that quality?
So it's a great question. What the market is telling us, right, what Medicare and policy is telling us, it's now our problem, right? I mean, I've always tried to do the best I can for taking care of patients in the window of time that I have to see them, but am I really, looking at their total health? Probably not. I mean, there's many reasons for that. I've got a clinic full of patients. You have a clinic full of patients. We do certain things. We don't do other things. But healthcare organizations are going to have to take on the role of integrating the care. So just a simple example, right? Stable patient with coronary disease, okay? Monday I'm in clinic. I'm sure I'm going to see this patient who probably will have seen his internist a week ago in the same healthcare system because it's appointment week. Okay, I gotta go see my internist and I gotta go come see my cardiologist. The value that I'm going to add to that patient's care is probably very little that day because it's a check the box. He's coming in to see me because it's his annual, and he's just been seen by talented internal medicine colleague who can take care of the things that he needs to. So it's two costs. Very little value to the patient, and we, as our organization, have zero capability of doing that. We don't even have the ability to say, look, see the internist and see me 6 months later. It gives us 2 shots to figure out if something's changing with you, right? We don't do that because there's been no incentive to do it. There's been no structure to do it. But if now it becomes my responsibility to take care of this patient over time within the constraints of cost and so forth, it's going to have us rethinking about how we structure care. And it's going to, require a new level of organization within service lines about how care is coordinated in ways, quite honestly, we haven't been challenged to do. But again, those in ACOs have been doing this for probably close to, 5 years now. So it's going to require new ways of thinking. Just that ability to put your head down and do your best job and, get things done in, 15 minutes and 30 minutes in the new environment is necessary but not sufficient. We're going to have to figure out other ways in terms of how we, orchestrate care, or otherwise we're just going to continue to see the spend.
Jeff, great to have you here. This is among the clearer presentations I've seen on a complex topic, and at times it's a downer, obviously, because of all these issues that are coming forward, and hopefully, quality will prevail while we're trying to do something about cost and care integration. A couple of questions for you. One regarding MIPS and APMs regarding, you said the vast majority of physicians will probably practice in the MIPS area.
Yep.
Where's the risk in the APM? I mean, it's all positive, obviously. Is the risk on the big organizations that have the ACOs, and how do you get along the physicians so that, because that risk is somewhere there through the practice as opposed to the big organization?
Yeah, so, I think that the alternative payment models give advantages to those systems that have already begun to organize care. Because it's not a free lunch if you're in an alternative payment model. You've already are meeting some financial benchmarks and quality benchmarks up front because you can consistently deliver that care in that way. So, you know, it's a reward if you're organized that way, but the setup and the infrastructure to create an ACO, for example, an accountable care organization, isn't something that's a, you know, weekend retreat. I mean, it's real work and purposeful work at a healthcare system level. Those who have moved along those lines and who are participating in that then get to sidestep this other, you know, cavalcade of, you know, measures in MIPS. So there's distinct advantage in it, but there's real work that needs to be done up front. The other point that comes into play with APMs that doesn't get the press, I mentioned that there's a 5%, you know, increase, if you will, in terms of payment, but that stops in 2024, and then everything goes to just even Steven. If you were a really elite team, right, you organized everything into a tax ID number just around cardiovascular providers, and you said, you know what, we're going to knock the socks off of MIPS because we know our quality measures and we know our cost and we know all of this, you're going to have 9% in perpetuity. That's a pretty good deal if you are really organized and can really perform, okay? If you're just going about business your usual way, and it's not an indictment on the care that we provide, but you're probably not going to do too well in an environment like that. So I think that, you know, in general, I mean, let's face it, PQRS, this issue of, you know, patient quality reporting system, you know, which has been the easiest thing to at least report on, there's a number of providers out there, Medicare patients, who just said, it's not worth my time. And I don't know what they're doing, whether they're just turning up the volume knob or something to make up for the revenue loss. So when we're thinking about this, in general, cardiovascular providers tend to be high performers in the whole Medicare nexus. Maybe it's how we're all wired, I don't know. But if you think about it from a just sort of game theory perspective, right, in a MIPS, you know, environment, if your service line is really well organized, has its own tax ID number that is just cardiovascular providers and not your gastroenterologist, rheumatologist, and everybody else who got put in there 10 years ago, there's a real opportunity there, I think.
Thank you, Jeff. That was a wonderful talk. It's great to see that an echocardiographer can also get into learning all these things and not only learning them, but
We're teachable.
not only learning them, but actually presenting them in a way that the rest of us can get a glimpse of it. One thing that I kept listening to you and said, gee, I wonder about this other part that you didn't have time to touch on, but whichever model one chooses,
Yep.
you're going to need to have a certain internal support structure to know how well you're doing. Without that, you're cooked. So here's my question. That internal support structure is going to cost some money. It's going to be part of your cost, part of your overhead. Mm-hmm. So how much of the reward is going to end up just paying for that extra type of people you need? And at the end of the day, the doctor really doesn't, you know, it stays neutral. Yeah. So what's going to be the cost of the support structure in either model that is needed to be able to perform well?
So it's a great question. And I think, you know, so the first issue when we talk about alternative payment models and ACOs and so forth, there's a significant cost up front in terms of standing up, right? So having your information systems, having your quality systems in place, your provider time to serve on committees, to do all this. The feeling, though, in the community, if you will, is Medicare piece is one aspect of this, but there's also the expectation that this is where the private insurance market is going as well, right? So that whether we label it as MIPS or we label it as APMs right now, tremendous technical details, but the same discipline is going to need to happen organizationally in terms of providing care, right? We can't have in the same geography as we had in Charlotte, one set of providers who thought 90% of the time bivalirudin made sense, and another 10% made sense. Now, it wasn't wrong that they were given bivalirudin. It was expensive, right? And there was no extra value from a medical sense. But unless you start putting systems into play where you're examining care at that level and saying variance is this and variance needs to be that, because it's the only way we're going to be able to, you know, deliver the product at the rates we're going to have coming back. Because at the end of the day, it is going to be a revenue issue back to your institution from somebody, and most institutions really don't understand what their actual costs are to take care of an episode. Again, any manufacturing company can tell you to the penny what it costs them to do X, Y, or Z. In medicine, most of us have no idea. And that era is coming to a close. Now, how and how quickly and so forth, like I said, if you're in the Kaiser system out west, what I just said is, yeah, I heard this 10 years ago, right? Right? You know, but for those of us, you know, I mean, from the southeast, it's just not, you know, hasn't really penetrated yet, but we know it's coming. So to your point, there will be infrastructure costs. It's new work. The question is, if you can do it really well, how do you get on the plus side? Because you are going to come out on the more efficient side with hopefully improving quality. If we can reduce care variation, we should improve quality, and we should improve effectiveness, and we should improve the patient experience. And I think that's what we all signed up for. And then the revenue piece takes care of itself. So, Jerry.
Yeah, great talk. Perhaps one last question, given the time. The disconnect in terms of disease severity from our progress note to what we bill, trying to influence claims data, severity assessment. What is the approach you're taking? Is it the EMR and having a structure put in to optimize? For us, this continues to be a challenge. I'm very interested in your just basic philosophy and your approach.
Yeah, so the question really comes down to, you know, coding and how do I convey that Mrs. Smith is really sick versus not. And again, this really requires team ball in the organization, and not just in the cardiovascular aspect of the organization, but across the board. So just to get into a little bit of detail. So there's something called a RAF score, risk assessment score, that Medicare calculates on everybody. And it's influenced by age and some demographic factors, but then it's influenced by disease state, okay? The RAF score goes to 0 January 1st every year. So you've seen somebody, you've been taking care of them for years, and you saw them last year 3 times, and you took care of all of their problems, their AFib, their diastolic heart failure, their, you know, diabetes with complications, et cetera, et cetera, et cetera. And Medicare knows that because you were diligent last year, and you know, when the nephrologist saw them, he or she billed and you billed and so forth, and a, you know, record has been created on a billing sheet. It goes to 0 on January 1st and starts all over again. And now you have to do the same thing. And if you don't, the patient who was really sick last year, now in Medicare, is this sick this year. That's just how it works. So and there's no way in the 15 minutes or 20 minutes or whatever you have for your return visits is you can start going through and you're trying to spend time face-to-face taking care of the patient. These other things, you know, have to happen. There has to be an electronic solution for that. And that's what we're looking at. We're on Cerner, and Cerner doesn't have the capability to do this, so we're actually looking at another product that helps with this. And it's not about inflating the chart or anything else like that, but again, how does the outside world know how sick your patients are? One last point, going back to this QRUR report, it will tell you how sick your patients are on a national basis. We came out on the expensive side last year in PCI on an outpatient basis. We couldn't really figure out why because we were really strong on an inpatient basis. Our scores of how sick our patients were we had like the healthiest patients in the country, which we don't, right? But it was a deficiency in our coding processes. So again, this whole issue organizationally and at a service line level, there needs to be a strategy. And I guess I would just say, you know, as a last point, and thank you again for having me, when this work starts to hit you as providers from other leaders in your organization, have a sympathetic ear, because it is work that is new, it's challenging, but it's going to be important, and we've got to figure out ways that it doesn't get in the way of our taking real care of our patients. But to dismiss it, I think, would really be, organizationally, a very difficult thing to do. Again, thank you very much. Appreciate it.